This meeting is being
refreshment?
recorded.
Should I start? Okay. My name is Elizabeth Sluderman, and I'm a certified diabetes nurse educator, and I am in the diabetes education program here at Mercy. And I'd like to welcome you this evening to Mercy's Diabetes Information Seminar. So we're going to start out with just kind of getting a little bit of a review about what diabetes is. Some of you may have diabetes or just be interested in diabetes. Many people have someone they know or in their family that have diabetes. So that is our goal this evening, is to learn more about what diabetes is, medications, monitoring. Dr. Chamaria is going to visit with us about heart disease and diabetes. We're going to have Jenna, the dietitian. So we're going to have a busy evening ahead. So how do we take control of diabetes? Thank you. All right, thanks. So what is diabetes? It's very common. It affects 1 in 13 persons. And if you really consider people with prediabetes, it's probably even higher than that. I would hazard to guess that in Sebastian County, it's probably higher than that. It's a chronic disease. It's lifelong. But it is controllable. And that's what you're here for this evening. It is controllable. Well, it is more controllable than this is, that's for sure. Can you just next it? All right. So what happens when we eat? A lot of what we eat is carbohydrate. Not everything that we eat is carbohydrate, but the majority of what we eat are carbohydrates. Carbohydrates are our energy source. It breaks down to blood sugar or blood glucose, and it is our source of energy. What is normal blood sugar control? Well, with people that do not have diabetes, their pancreas produces insulin in response to blood sugar rising, and that insulin helps us control blood sugar and keep it within a normal range. What is a normal range? Before meals, 70 to 130. And 2 hours after a meal, less than 140. Now, everything I quote to you tonight on numbers is going to be by the American Diabetes Association. Your physician may have recommended other numbers for you, but they'll be pretty close. So what happens when blood sugar goes high? Either we don't make enough insulin, the cells don't open up and accept the insulin correctly, or sometimes livers, even though they're not damaged, livers can release too much glucose into the bloodstream. Why do we care? Why is this such a big deal? It's a big deal because of chronic complications. It can affect every blood vessel and every nerve ending in your body. So it's a big deal. It is the leading cause of blindness, non-traumatic blindness. It's the leading cause of kidney disease. It can lead to cardiovascular disease, loss of circulation, nerve damage. So therefore, it is a big deal. There are two main types of diabetes. Type 1 diabetes. Type 1 diabetes is when the pancreas quits making insulin. It doesn't mean that the pancreas is damaged. It doesn't mean that there's a disease process going on with the pancreas. It's just that portion of the pancreas that makes insulin quits making insulin. Only about 10% of the people that have diabetes has type 1 diabetes. 90% of the people that have diabetes have type 2 diabetes. Type 2 diabetes is a little bit more complicated. Type 2 diabetes means that either the cells don't accept the insulin and open up and allow the sugar in to be converted to energy, or maybe over time the pancreas gets to where it makes some insulin, but it doesn't make enough insulin, particularly for the requirement. So you've probably heard type 2 diabetes and insulin resistance. So type 1 is insulin deficiency, type 2 is insulin resistance. So what are the symptoms of type 2? And because I was trying to get a lot of slides in a little time, the symptoms of type 1 and type 2 are the same. It's increased thirst, increased urination, feeling very tired, because remember that sugar is our energy source, blurred vision, because when we have increased urination, we get dehydrated. When we get dehydrated, the eye can change a little bit, the lens on the eye, and it can cause blurred vision. More frequent infections, because it takes very good healing to heal, and high blood sugars of themselves can slow down the healing process. For people with type 1 diabetes, these usually occur more rapidly. For people with type 2 diabetes, these symptoms may boil along for many years before the true diagnosis of diabetes occurs. But typically, the symptoms of high blood sugar, thirst, frequent urination, blurred vision, fatigue, those symptoms don't typically occur until blood sugars are running in the 200s, yet we know that damage to blood vessels and nerve endings occurs when blood sugars run over 150. So we have to be very aware of what our blood sugars are. What is the treatment for type 2 diabetes? Because that's what most people have. For type 1 diabetes, it must be insulin. For type 2 diabetes, it's always education. It's always healthy eating, checking blood sugars and physical activity. Some people with type 2 diabetes may take oral medications. Some people may take injectable diabetes medicines. Other people with type 2 diabetes may take insulin. So many people think that if you start taking insulin, all of a sudden you become type 1. That's not necessarily the case, and it's very rarely the case. That insulin may be a supplement. So our diabetes management plan, like I just mentioned, includes healthy eating, physical activity, monitoring blood sugars, taking medications as needed, and definitely education. Because if you know more about what's going on, it's a little bit easier to manage it. Making sure that we get carbohydrates. I mentioned that at the beginning. You hear a lot about how many carbohydrates to eat, how many carbohydrates not to eat, what's a good carbohydrate, what's not a good carbohydrate. Well, Jenna back there is going to go over carbohydrates with you here in a little bit. But carbohydrates are necessary because they are our first-line energy source. Some good things that we need to know about physical activity. We always hear about diet and exercise, right? Helps everything, diet and exercise. Well, one thing we need to know when we talk about muscle movement with diabetes is that these are muscle cells and these are fat cells. And if those muscle cells are in better shape, they will be less resistant to insulin. So any exercise beats no exercise. This is the only exercise I don't want you to increase, okay? We don't need to do more of that. But we do need to move muscle so that our body accepts that insulin and utilizes that insulin more efficiently. A little bit of weight loss. You hear that too, don't you? We need to lose weight. Well, what does weight have to do with it? Well, it's simple. The more bulk we have, the more insulin it takes to open up the cell doors and decrease insulin resistance. What is type 2 diabetes? Insulin resistance. So the more bulk we have, the more insulin resistant we are. We may not develop diabetes, but we are more insulin resistant the more weight we carry. So know your target ranges. So we talked about normal is 70 to 100, and 2 hours after a meal, 2 hours after the beginning of the meal, normal is less than 140. What is your target range? That is a communication for you to have with your primary care physician. But again, the ADA guidelines say 70 or 90 on the low side. If you're taking insulin or an oral agent that can lower blood sugar, your goal is 90 to 130. If you're not taking a medication that can cause a low blood sugar, then the target is 70 to 130. And the whole goal of that is to not cause low blood sugars. We want to control blood sugars without causing a low. We definitely want to prevent low blood sugars. We check blood sugars to see what it is, because at 150, you're not going to feel thirst and frequent urination. So we have to check blood sugars. There's all kinds of gizmos out there these days. There's continuous blood glucose meters. I was off work one day and I was watching TV, and I think every other commercial on TV was about a continuous blood glucose meter or something to do with diabetes. So you've seen a lot of information. If you have a question about blood glucose meters, ask your educator, ask your physician, ask your pharmacist. John will tell you that. Ask the pharmacist. They can direct you on a blood glucose meter. Many insurances will reimburse at least partly on blood glucose meters. Some do not. So that's a good conversation for you to have with your provider and your pharmacist. Lab test A1c is a 3-month blood test. It can look at your average blood sugar over the last 2 to 3 months. When you do a blood sugar prick, it tells you what your blood sugar is right then and there. But an A1c has a way of telling you what it has been on average. Other tests that you may have done is a urine protein, blood lipids. You may have liver function tests for some of the diabetes medicines they give. You may have a creatinine or a BUN or a GFR. I'm throwing out lots of different lab tests that have to do with how your blood sugars are affecting the rest of your body. So be familiar with those. Again, people with type 1 diabetes must inject insulin, either by pump, injections. There's an inhaled insulin. I don't see it around here very much, but you must have insulin. People with type 2 diabetes may or may not require medication, including insulin. Causes of high blood sugar may be that they don't get enough medication. It may be that we outate what our own body can make in insulin or what we use as medication. Stress, be it physical or emotional. Stress can raise blood sugar. Steroids, if anybody's ever been on steroids, you know that they do wonders. They're good for lots of stuff, but frequently they do cause an elevation in blood sugar. So remember the symptoms of high blood sugar. If you or someone that you're around is experiencing these types of symptoms, please keep diabetes in the back of your mind and have it checked. Be prepared for sick days because illness can raise blood sugar. That's not the day when you're ill that you want to go to the pharmacy and get all your cough and cold medications. And please get the immunizations for flu and pneumonia. We're going to discuss the large blood vessels, the heart, and we're not tonight going to cover eyes, but the tiny blood vessels in the back of your eye called the retina, those are very often damaged from prolonged high blood sugar. So the benefits for type 1, the benefit of controlling blood sugar A1c under 7 or blood sugars less than 150 on average can reduce the risk of eye problems that lead to blindness by 76%. So controlling blood sugar isn't just one of those things you say, that would be nice, it's a good thing to control blood sugar. It's a must because we want to make sure that our body parts are not damaged. With type 2, the information that we have isn't quite as dramatic, but I've been here forever, and I can tell you that it makes a big difference whether blood sugars have been under control or not. So adopt a healthy lifestyle, have a good communication with your provider. If you're smoking, don't smoke because that alters the oxygenation, and we want those red blood cells to carry a good oxygen supply. Go to your eye doctor at least once a year. This doesn't mean that you need new glasses. What they're doing is they're looking at the back part of your eye called the retina. Having your lab work drawn very often can give a good indication of what your kidney function is. Not whether you're urinating or not, but they can tell by blood work or a urine test what the function is of your kidneys. Foot care, keep your feet healthy, don't abuse your feet. As we get older, it gets a little harder and harder to look at the bottoms of our feet. So a handheld mirror very often will help look at the bottoms of your feet. Tips for foot care, examine your feet daily, wash with soap and water. Don't put lotion between the toes because that tends to stay moist anyway. If you can't feel your feet, then feel the inside of your shoe with your hand. I had a gentleman that when I asked him to do that, he felt on the inside of his shoe and found a thumbtack. And fortunately, we were able to get it out before it caused any damage. Schedule regular visits with your primary care provider. Realize that having diabetes can kind of be in an emotional roller coaster. So find someone that you can communicate with and that has a good understanding. The good news about diabetes is that keeping blood sugars under control, you can prevent those long-term complications from occurring. Do whatever it takes. The meal plan, you don't have to be perfect, but work on it most of the time. Learn how to check your blood sugar if you aren't already checking blood sugar, because you want to know what those blood sugars are. You can't wait till you feel bad. And take the medications that you need to control that blood sugar if medication is needed. Know your diabetes care team. Have that communication. Here are some resources. I can share these more with you after the presentations are over, but there's lots of resources. A big one is just going on your website. Diabetes.org is the American Diabetes Association. The American Dietetic Association has a website as well. So utilize that information. The American Association of Diabetes Educators has 7 rules, and it is healthy eating, being active, checking blood sugars, taking your medications, problem solve, try to find out what's going on. Healthy coping because this isn't easy, and no one's saying that this is easy day to day. Reduce your risk of complications. All right, so I am going to announce or introduce our next speaker. Dr. Chamaria is an interventional cardiologist here at Mercy. She was born in Bangalore, India, where she received her initial medical school training and subsequently moved to the United States for her residency and fellowship. She did her interventional cardiology training at Mount Sinai in New York. She specializes in coronary artery disease and peripheral vascular disease. She's passionate about educating the community and spreading awareness about cardiovascular disease. So thank you and welcome, Dr. Chamaria. It works very slowly. Advance, but slowly. There you go. Thank you.
Good evening, everyone. My name is Surabhi Chamaria. I'm one of the interventional cardiologists here at Mercy. Thank you for coming out today, and thank you to the diabetes team for organizing this. It's very, very important to be aware of your disease process and know the risks related with diabetes. Well, thank you, Liz, for that talk. It was very informative, very important to know, what to do with our diabetes, how to diagnose it, and then what we can do to control it and control the complications related with diabetes. I'm just here to talk to you about some of the signs and symptoms related to cardiovascular disease. And as we know, cardiovascular disease is the #1 killer today. And patients with diabetes are at a 10-fold risk for developing cardiovascular disease. Cardiovascular disease includes a spectrum of atherosclerotic cardiovascular disease. That just means that it can affect your brain, causing you to have a stroke. It can affect your heart, causing you to have a heart attack. It can affect your kidneys, causing you to develop renal failure. It can affect your legs, causing you to have poor circulation, pain in your legs, ulcers in your feet that don't get healed, eventually leading to loss of limbs. All of these can be prevented by knowing your disease process, knowing how to control it, what needs to be done for it, your medications, diet, and most importantly, lifestyle modification. I'm just waiting here for presentation slides. Well, you guys do have some brochures handed out to you all with a lot of education material on it, what to look out for. We do have booths set up to talk to you about stroke and diabetes. There's someone representing the pharmacy over here to help you with your medications. You do have some of the slide presentations listed out just for you to carry home and read to know how to diagnose diabetes, what your blood sugar levels should be, what your blood pressure should be, what your cholesterol levels should be, and what are the complications you can develop with it. If you have any of these signs and symptoms and you feel like you need to talk to a cardiologist, please pick up the phone and call our clinic. My card is over there along with my nurse practitioner's card, who's here, Andrew. Feel free to call our clinic and we will definitely get you in and help you through your disease process.
Packets, if you can just direct them from slide 2.
to the other bits. Looks like we got to go. That's all we needed. Yeah.
Looks like we finally have something going. Well, there we go. All right. So, a lot of this may be medical jargon, but I'm going to try to talk with you in common man's terminology so you all can understand what I'm trying to communicate here. This slide basically tells you, that diabetes, the complications related with diabetes is, macrovascular complications and microvascular. What that basically means is that diabetes can affect your large blood vessels and it can affect your small blood vessels. Large blood vessels leading to a heart attack, a stroke, or poor circulation in your legs. Small blood vessels implying can lead to damage to your eyes, causing you to have blindness, damage to your kidneys, causing you to have renal failure. Like you can see over here, these complications basically start before you're diagnosed with diabetes or in the pre-diabetes condition, and Liz had mentioned this in her previous slide. By the time you're a full-blown diabetic, you already have some of the macrovascular and microvascular complications, and hence it's very important to know whether you're in your pre-diabetic state and check your blood sugars often. What are these pre-diabetic conditions that we keep talking about? There are basically two of them. One is impaired fasting glucose. That just means that when you wake up in the morning and check your blood sugar the first time after having an overnight fast and your blood sugar is between 100 to 125, you're in that pre-diabetic state. The other terminology that we always talk about is impaired glucose tolerance. What does that mean? It means that when you check your blood sugars after consuming 75 grams of glucose, if your blood sugars are between 140 to 199, you are already in that pre-diabetic state. That means you got to act now to do something to control that blood sugar of yours before you progress to becoming a full-blown diabetic. What is diabetes and how do we diagnose it? The best test out there is to check for an A1c. If your A1c is greater than 6.5, you probably know that you've had diabetes for the last 2 to 3 months. There are other ways of checking it. One is a fasting blood glucose, like we said, between 100 to 125, you're in the pre-diabetic state. Anything above that, you're probably a diabetic. You can also check your blood sugar randomly. If your blood sugar, randomly is greater than 200, then you're probably a diabetic. This is sort of an eye-opener for all of us. In 2015, the US population was about 30 million. Of these, you can see 7.2 million of them were undiagnosed, and 84.1 million patients were in the pre-diabetic state. That just tells you the magnitude of this condition and how underdiagnosed patients are with diabetes. This gives you a breakdown by age, ethnicity, and sex and race. The people who have the highest risk for developing diabetes are the American Indians and the Alaskan Natives. And like you can see, most of the times, men have a higher risk for developing diabetes than women. This is a study that was shown to look at what is the cardiovascular risk of patients who are in their pre-diabetic state. They haven't even been diagnosed with diabetes. And both these studies show that if you have impaired fasting glucose levels or impaired glucose tolerance, you are already at a very high risk for developing cardiovascular disease. So you don't have to be a diabetic to have your risk doubled. If you're in that pre-diabetic state, you already have your risk doubled for developing cardiovascular disease, and hence the importance of controlling your diabetes then and there. So, diabetes is a prime risk factor for cardiovascular disease. Like we said, it can affect your big blood vessels, cause you to have a stroke, cause you to have a heart attack, cause you to lose your limbs, or it can affect your small blood vessels. It can also lead to weakening of your heart muscle and cause you to have heart failure. Now, diabetes and high blood pressure go hand in hand. Like you can see, 40 to 80% of diabetics already have high blood pressure. And diabetics, or if you have diabetes, you're 2 times more likely to develop high blood pressure. Why is this very important? Both diabetes and hypertension play a very important role in causing progression of atherosclerotic disease. Both of these can cause damage to your small blood vessels, damage to your heart, damage to your lower extremities, and cause you to have a stroke. So very important that not only you control your diabetes, but at the same time, you control your high blood pressure. Now, what can diabetes do to you? This is a lot of information to assimilate. But basically, if you see, diabetes can increase your risk of infection. It can decrease your immune system, cause you to have an increased risk of infection, which in turn is going to increase your blood sugar levels, which in turn is going to cause uncontrolled diabetes. It can cause you to have inflammation. What does inflammation do? It causes progression of atherosclerotic disease. It can cause you to develop insulin resistance, and hence your diabetes will not be controlled. It can cause you to have abnormal cholesterol levels. Diabetes increases your bad cholesterol and decreases your good cholesterol. What does diabetes do to your blood counts? Diabetes basically causes clumping of your platelets that leads to progression of atherosclerotic disease, blockages in your heart, blockages in your legs, blockages in your brain, and hence you can come with a stroke, a heart attack, or come in with losing your leg. This is a very important study. This basically was a study done in Finland, and it looked at patients who have diabetes and who don't, and who have cardiovascular disease and who don't. The most important thing to take away from here is patients with diabetes but no cardiovascular disease experience a similar rate of heart attacks as patients without diabetes but with coronary heart disease, implying that if you are a diabetic and you have heart disease already to begin with, your risk of having a cardiac event in the future is almost 10-fold higher than patients who don't have diabetes. This looks like our mortality in patients who have diabetes, who have heart disease, and who have diabetes and heart disease. So if you look at the light blue bar, it basically is those patients who have heart disease and diabetes. And like you can see, those blue bars are the tallest, implying that those patients who have diabetes and heart disease have a higher risk of dying, be it from any cause, and a higher risk of dying from heart diseases. This looks at the hospitalization in the United States patients who are diabetic and the complications related to diabetes. So if you can see, if you are a diabetic with any complication of diabetes, there were about 7,000 patients admitted in 2014 just with the diagnosis of diabetes. And if you break it down according to the cardiovascular disease, the highest number of patients who had cardiovascular disease and diabetes were admitted in 2014. So what are the risk factors associated with diabetes and heart disease? Very, very important. High blood pressure. What does high blood pressure do? It increases our insulin resistance. Abnormal cholesterol and triglycerides. What do? They increase our propensity of progression to cardiovascular disease. Obesity. Obesity increases our insulin resistance, decreases our insulin sensitivity. Lack of physical activity. Liz gave us a very good explanation of why physical activity is very important and how it helps to improve our insulin sensitivity. Smoking. Smoking releases a lot of toxins that causes progression of cardiovascular disease. Smoking also increases our cholesterol levels, and hence it's very, very important that we stay away from smoking. Now we talk about atherosclerotic cardiovascular disease. What are the symptoms of this? Heart attacks, so acute heart attacks, or chest pains that we call angina, strokes, or peripheral arterial disease implying poor circulation of your limbs. So what is atherosclerosis? It's basically a disease in which plaque builds up inside your arteries and limits oxygen-rich blood going to your organs. And it could be anywhere. It could be in your eyes, it could be in your carotid arteries, it could be in your kidneys, it could be in your heart, it could be in your legs. So plaque building up anywhere is atherosclerosis. So what are the warning signs of heart attacks? You know, all of us may not come with typical symptoms of crushing chest pain, short of breath, diaphoresis, sweating, radiation of pain, but we need to know what the typical symptoms are. So if you look, pain and discomfort in the chest, most important sign. What are the other signs and symptoms? We may be lightheaded, we may be nauseous, especially diabetics because we have damage to our nervous system. We may not feel the pain in our chest. We may just come with lightheadedness and dizziness and nausea. especially women. They come with very, very atypical symptoms. Or we can have jaw or neck pain or even back pain. Some patients come to me and they say, I only have back pain, I'm not sure, I just have pain in between my shoulder blades. That could be a sign of a heart attack. Discomfort or pain in the arm or shoulder. A lot of us think, oh, it's just related to, a muscle pull or, arthritis in our shoulders. But if you're a diabetic and you're having these symptoms for no other cause, it's possible you're having a heart attack. Difficulty in breathing. Why do we develop difficulty in breathing? Because the blockage causes decreased blood flow, decrease in delivery of oxygen to our heart, and hence it causes us to be short of breath. If you're having any of these signs of heart attack, what can you do? Call 911. Please go to the ER. Please do not drive yourself to the ER. Once you get to the ER, you're going to have an EKG done. If the EKG doesn't show you're having an acute heart attack, then there will be some other tests ordered to figure out whether something else needs to be done more invasive. That could be an ultrasound of your heart to look for your heart pump function. That could be a stress test, and that's going to guide further treatment to determine what we need to do if you're having a heart attack. What are the signs of stroke? We've all seen this. We have fridge magnets available for you guys over here to keep with you. If you're having, sudden onset of drooping of one side of your face, if you're having any sort of arm weakness or leg weakness, if you're having difficulty in talking, these are very, very important signs, and time is of the essence. Why? Because you have a 3-hour window to get to the ER. Say you started having symptoms at 10 p.m. You need to go to the ER right away, because if you're truly having a stroke and it shows that there's an artery that's clotted up in your brain, you have a 3-hour window for us to give you clot-busting medications, which could be life-saving. So if you feel like you're having a stroke, don't wait it out. Don't wait for the symptoms to improve. Get to the closest urgent care or get to the closest ER. Now, what are some of the signs of developing peripheral arterial disease? Lots of patients come in with saying, my legs tire when I walk, but they improve with rest. Or you have cramping of legs or your calf muscles. You can't walk very far because you start hurting. Or you have wounds, very, very important, especially in diabetics. You are not going to be able to feel, the soles of your shoes, or you're not going to be able to feel the surface. You have neuropathy. If you start noticing that you're developing an ulcer, then it's very, very important that you get to your physician as soon as possible, because you're probably having poor circulation. If we don't reestablish that flow in your legs, the wound is never going to heal. Probably it's going to lead to loss of a limb. Now, the other important thing to remember is that if you have poor circulation in your legs, you're at a very, very high risk for having a heart attack and a very high risk for having a stroke. So if you have symptoms where you feel like you can't walk a block or you can't walk half a block, then you know that you have poor circulation in your legs. You need something to be done. Once you determine that you think you have poor circulation, what are some of the tests we can do? We can do a simple ultrasound of your legs to see or measure certain parameters called ABI, where we measure pressure in your arm, pressure in your legs, see if they are abnormal. If they're abnormal, you probably have poor circulation. We need to do something about it. Or we can get a CT scan of your legs to see if there are any blockages and whether we need to open it up. Just like we can open up blockages in the heart with stents, we can open up blockages in the legs with stents. What this slide basically tells you is that, if you're having pain in your legs, different areas of the leg represent different arterial blood supply to the leg. So if you have pain in your thigh or your buttock area, a different artery is involved, one of the big arteries. If you have pain in your calf muscles, then we know which artery is involved, so we know how we can fix it. Most important thing to remember is the bottom half of the slide, which is called acute limb-threatening ischemia. It's like a heart attack of the legs. So if you start noticing that you're having pain in your legs at rest, if you start noticing that your legs are getting pale or white, if you start noticing that you're not having any pulse or you're not feeling the pulse in your legs, if you start noticing that you're having tingling and numbness in your legs, or you feel like your legs are always cold, that means you're having a heart attack of your legs. It's very, very important that you go to the ER right away, because if you're not able to establish blood flow to your legs, then you can even lose your leg. Now that we know what diabetes can do to you, what do we do to prevent it or to control it? So basically, the American College of Cardiology, has come up with a scoring risk factor. It's called an atherosclerotic cardiovascular disease risk factor. And that basically scores you according to certain risk categories and tells you what is your risk of developing heart disease. Now, this is a very complicated slide, but this slide will help physicians risk stratify you. So on the top, if you see in green, if your cholesterol levels are greater than 190, then automatically you need to be on cholesterol medications. If you are a diabetic between the age of 40 to 75, you need to be on cholesterol medications. If you're a diabetic between the age 40 to 75, then we can consider other risk factors to see if you need a higher dose of cholesterol-lowering medications. If you're none of those, then we calculate a risk called an ASCVD risk. You don't have to wait for your physicians to calculate that. That is very, very easily available online on a phone app. You can just pull up ASCVD risk factor. It'll give you these parameters to plug in. Once you plug in these parameters, you can calculate what your risk score will be. If your risk score is greater than 7.5%, you are at a very high risk for developing cardiovascular disease. At that point in time, you need to talk with your doctor and discuss whether you need to be on cholesterol-lowering medications, whether you need to be on aspirin. This is freely available. You can calculate this yourself if your doctors have not already done it for you. Now, who should be tested for diabetes? All overweight adults with another risk factor. If you're physically inactive, if you have a first-degree relative who is a diabetic, if you fall in one of those ethnic populations that are high risk for developing diabetes, women who deliver babies greater than 9 pounds, they have very high risk for developing gestational diabetes and continue to become chronic diabetics. If you have high blood pressure or you are on treatment for it, and if your cholesterol levels are abnormal, if your bad cholesterol is high and your good cholesterol is low. What are the 7 simple ways to keep a healthy heart? Avoid smoking and using tobacco products. Be physically active every day. Eat a healthy heart diet. Keep a healthy weight. Keep your blood pressure healthy. Keep your total cholesterol healthy. Keep your blood sugar healthy. If you can follow these simple 7 ways to keep your heart healthy, I guarantee you, you probably will never have any of those acute problems related to your heart. So, the American College of Cardiology and the American Heart Association recommends at least 150 minutes of moderate intensity physical activity. Now, a lot of my patients will come in and say, I don't have access to the gym. I can't afford it. I don't have time. I have a very busy life. We just recommend brisk walking. You can get out there, you can walk. If it's too hot, it's too cold, find an indoor walking space. There are multiple malls available. They have indoor walking trails. If you work at the hospital here, Mercy has a walking mile. All it takes is 30 to 45 minutes of brisk walking 5 times a week to keep that physical activity going. These are some of the other physical activities available, and a lot of you may not be able to get to the vigorous physical activity level, but start with brisk walking. If you can't do 30 minutes at a stretch, 15 minutes in the morning, 15 minutes at night. Pick up your stamina and go on from there. This is a very important slide because it tells us what physical activity does to us. Physical activity reduces our insulin resistance and increases our insulin sensitivity. So if you're physically active and you're losing weight, maybe your insulin requirements are going to go down. Your blood sugars are going to be very well controlled. Next. Now, the importance of blood pressure control and who should be on blood pressure medications. So blood pressure should be measured at every visit. If you have high blood pressure, then get a blood pressure machine at home. Log your blood pressure once a day, every day. Take that log to your physicians because that's going to help us guide and tailor therapy for you. Patients with a blood pressure of greater than 130 on the top number and greater than 80 at the bottom number should have blood pressures measured every day and confirmed at separate visits. If you have a blood pressure that's greater than 130 and greater than 90, then of course the first thing we recommend is lifestyle modification. Now, what is that lifestyle modification that we talk about? Weight reduction. What will weight reduction do? It's going to decrease your blood pressure by 10 points for every 10 kgs that you lose. Adopt a DASH eating plan, which is basically a Mediterranean diet. Decrease your sodium intake. What is that going to do? It's going to decrease your blood pressure by almost 8 points. Physical activity, moderation of alcohol consumption. All of these, like you can see, is going to decrease your blood pressure, and it's possible eventually you may get off blood pressure medications. What are the sources of dietary salt? Like you can see, 81% of our salt intake comes from processed foods. Those are quick foods to get to, they are convenient foods to get to. Life happens, we don't have time, we pick up that can of food and we eat it. Look at the sodium content on that can of food. The sodium content is probably pretty high, and that's driving your blood pressure up. If you can cut off those processed foods, you're going to significantly cut off the amount of sodium that you're taking in. Cooking salt has about 6%. Table salt has about 9%. Of course, water barely has any salt. Very, very important that you cut off the salt intake. We recommend about, obviously, no salt to minimal salt a day, about 1.5 to 2 grams a day. Now, what are the recommendations for cholesterol? All patients should have a cholesterol level checked at least every year. We talked about that risk factor. If you fall under any of that risk factor categories and your ASCVD risk score is greater than 7.5%, you need to be on a cholesterol lowering medication. Lifestyle modification definitely is the first thing that we need to do to reduce that cholesterol level. So, comparison of dietary fat. Which kind of fat should you be eating? The most important kind of fat that you want to be eating is that polyunsaturated fat. Like you can see the ones in the blue and the ones in the red. The saturated fat and the monosaturated fat are the ones that are not good for you. So whenever you're, buying food, buying canned food, look at the fat content on it. If it has a lot of saturated fat, if it has a lot of unsaturated fat, you should probably not be eating that. So eat foods that are low in saturated fat, trans fat and cholesterol, and moderate in total fat. Every time you eat a burger, think of this. 1 burger, you're going to get 1 bypass surgery. 2 burgers, you're going to get 2 bypass surgeries. You get up to 4, you're definitely going to get a quadruple bypass surgery. Tobacco smoking. We cannot emphasize enough how bad smoking is for you. All patients should be asked about tobacco smoking. We need to advise every person to quit smoking. You can find a lot of helpline services. Arkansas has a free helpline service available. Cards are available for you guys. So pick up the phone and call. If you need help with quitting, talk to your primary care physician, talk to your endocrinologist, talk to your cardiovascular physician, talk to your APNs. We are all here to help you, and you can definitely quit it. A lot of patients ask me about, supplementation. Should I take vitamins? What are they going to do for me? Are they going to help me with my cardiovascular disease? Routine supplementation is not recommended by the American College of Cardiology. So we're not going to routinely tell you take any antioxidants or vitamin E's and vitamin C's. They are usually not beneficial for you unless you're deficient in it and you have symptoms related to the same. A lot of patients ask me, should I be on aspirin? I'm a diabetic. So the American College of Cardiology gives it a class 2A recommendation. That means it's not very high on the list. But we can recommend aspirin for patients who have a high risk for developing cardiovascular disease. So if you calculate your ASCVD risk score and it's greater than 10%, sure, we can prescribe an aspirin for you, given that you don't have any bleeding complications. So in conclusion, what are the complications related to diabetes? Heart attacks, strokes, poor circulation. And these, you need to know that you can develop these before you're a full-blown diabetic. Even in your pre-diabetic state, you can develop these conditions. Lifestyle modification is the foundation of prevention or progression of diabetes and its associated complications. So get out there, exercise 30 minutes a day, 5 days a week. Watch what you're eating, look at the fat content in your foods, look at the sodium contents in your food. Think about that burger and think about the bypass. What are the warning signs of cardiovascular disease? If you feel like you're having a heart attack, if you feel like you're having a stroke, if you feel like you're having a heart attack in your legs, pick up the phone, call 911, get to the ER. Seek help. Your physicians are here to help you. We have diabetes educators. We have dietitians. We're all here to help you. You have free helplines. If you feel like you need help, please seek help. Call our clinic. Our cards are available. I have my card up there at the desk. I have my nurse practitioner's card up there at the desk. If you feel like you need to see your cardiovascular specialist, please call our clinic. We'll definitely get you in. And stay healthy, most importantly. Any questions? All right, thank you.
I'd like to thank Dr. Chamaria for that excellent presentation. The cheeseburger was really a visual, wasn't it? All right, we're going to change the agenda just slightly so we can reset the stage. So we do have time to take a break. Please get a refreshment or snack if you haven't already done so. Give us about 5 or 10 minutes, about 5 minutes. Restrooms are up here. The restrooms are also out that double door. Take about 5 minutes, get you some snacks, and we'll reset the stage a little bit.
That's probably good.
So right before We're going to meet back in just a minute or two, so if you can get your snacks and have a seat. All right, we're going to go ahead and get started with our next speaker. I'd like to thank Dr. Chamari. I guess she's already left, but that was a fantastic presentation. So our next speaker is Rachel Jones. She is with Nephrology. She is a nurse practitioner, and she's actually going to do some of the introduction herself because she's going to introduce some of the folks in her clinic. So, Rachel.
Hey guys, can y'all hear me? Is this on? Okay. All right, so I'm the nurse practitioner over in nephrology, and I'm going to do a presentation called Be Kind to Your Kidneys. So if y'all have any questions throughout, just feel free to stop and ask. I'm also going to take questions at the end too as well. All right, so Dr. Chamaria kind of spoke a little bit about how diabetes affects your kidneys, but I'm going to elaborate on that for y'all. So this is just a cartoon of some kidneys. Hopefully your kidneys are like this, happy and healthy right now. So what is nephrology? This is confusing for a lot of patients. Nephrology is a specialty of medicine that is responsible for diagnosing and treating kidney disease. So we see patients who are on dialysis. I go to Fort Smith Regional Dialysis Unit. I'll actually be there later this week. All the doctors in nephrology also see patients at dialysis. They also go to dialysis at POTO as well. So at Mercy Clinic, here we're in the old Cooper Clinic building. We see patients who have chronic kidney disease, and we monitor their kidney function and try to prevent our patients from having to start dialysis. So that's the goal, is for patients not to end up on dialysis. So the doctors in our practice also see patients at Mercy Hospital as well. I don't go over there, but the other physicians do. So these are the physicians at Mercy Nephrology. Dr. Coleman Sr., he has actually been practicing for, I think, 46 years now, so quite some time. And then his son, Dr. Coleman Jr., he joined the practice in 2000, so he's almost been doing this for 20 years now. Dr. Rotaro, he joined the clinic in 2015. The Colemans recruited him from UAMS, so he's fairly new to the clinic. And I'm the nurse practitioner. I joined nephrology in 2015, right before Dr. Rotaro, and I was a nurse, and I went back to school and got my master's degree at UAMS, and then came back. So I'm back at the clinic back home. So I know the physicians pretty well. They're all really great physicians. You may or may not be referred to nephrology at some point, and I'll kind of go over that with you. So why am I here today to talk to you about your kidneys? Well, diabetes is the #1 leading cause of chronic kidney disease in the United States and worldwide. Another fun fact is hypertension or high blood pressure is the 2nd leading cause of chronic kidney disease. So a lot of patients, y'all may already have high blood pressure, be treated for high blood pressure. So that increases your risk of developing chronic kidney disease. All right, so let me tell you about kidneys. I have a picture over here to the side. Kidneys are remarkable organs. So they are about the size of a computer mouse, and they filter all of the blood in your body every 30 minutes or so. Inside them are millions of tiny blood vessels that act as filters. Their job is to remove waste products from the blood. So they filter out fluids and electrolytes and help produce urine. They also help control blood pressure, stimulate production of red blood cells, keep your bones healthy, and regulate blood chemicals that are essential to life. Kidneys that function properly are critical for maintaining good health. However, more than 1 in 7 American adults are estimated to have chronic kidney disease. So it's very common. We see a lot of patients over in nephrology. In fact, we have a lot of patients that are new patients that we haven't seen yet. I think we're scheduled out to about April right now. Sometimes this filtering system breaks down. Diabetes can cause damage to the kidneys, and the million of tiny blood vessels that act as filters can cause them to fail. So failing kidneys lose their ability to filter out waste products, resulting in kidney disease. Now, who gets kidney disease? Not everyone with diabetes will develop kidney disease. So factors that can influence kidney disease development include genetics, blood sugar control, blood pressure, age, dehydration, and a variety of other different things, including medications. Some medications can hurt your kidneys. The better a person keeps their diabetes and blood pressure under control, the lower the chance is of a person being diagnosed with chronic kidney disease. So what are the symptoms of chronic kidney disease? I have a lot of patients that, come into my office and maybe their very first time seeing me and they say, I pee just fine, there's nothing wrong with my kidneys. And then I have to, kind of educate the patient and say, there are actually usually no symptoms of chronic kidney disease until it's in the late stages. And we don't want it to get that bad. So that's why we monitor patients in our clinic. This is why it's so important that you see a primary care provider regularly and are doing your regular lab work to screen for chronic kidney disease. So as you go to your primary care physician, probably every 3 months or so, they're going to look at your lab work and make sure that you're not developing chronic kidney disease. And I'm also going to tell you some things to kind of look out for on your own as well. So the kidneys work very hard to make up for the failing capillaries that have been damaged, maybe by diabetes or by high blood pressure. So kidney disease usually doesn't produce any symptoms until almost all function is gone, also known as time for dialysis, and we don't want it to get that bad. So that's why it's important for you to come see us if your primary care physician refers you to nephrology. I have a lot of new patients that are on my schedule and they don't show up. I don't know if they just don't know, what nephrology is. It's very confusing. But if your primary care refers you to nephrology, it's very, very important that you come to your appointments, because we're here to kind of we're like another set of eyes on you. So they are going to be looking at your kidney function and things as well, but we help them out a lot. So the top complications of diabetes. Dr. Chamaria spoke to y'all a lot about this, but I'm going to kind of go over some as well. There are eye complications with diabetes. This is called diabetic retinopathy. Remember how I told you that with your kidneys, there's tiny blood vessels that can be damaged, capillaries that are in your kidneys. This is not that much different. These are just tiny blood vessels in your eyes. This is why it's important for diabetics to have regular eye checkups. So if you're not, getting your eyes checked out, then you need to make sure that you are, okay? Another thing is diabetic neuropathy. I also heard Dr. Shmaria talk to you a little bit about this as well. This is nerve damage due to diabetes. Around half of all patients that have diabetes also have some kind of nerve damage as well. The signs and symptoms of this are numbness, tingling, and pain that's usually in your feet. Symptoms may be worse at night. I hear this quite a bit. Some patients may also develop, some diabetes patients may also develop wounds on their feet, or I've heard of patients maybe stepping on something like an air vent or something that's on the ground and they can't necessarily feel it, if they don't have good feeling in their feet. So it's very, very important that you have frequent foot checks by your primary care provider. So when they tell you to come into their clinic and take your socks off, this is why. They want to look at your feet. But you're only going to the doctor every 3 months or so. It's important that you also look at your feet, because you may not feel it and you may have something like a cut or a scrape or something on your feet. Another complication of diabetes, of course, is chronic kidney disease. That's what I'm here talking to y'all about today. This is why it's important that you keep your diabetes and your blood pressure under control to lower your chance of getting chronic kidney disease. Dr. Chamaria talked about this quite a bit, but high blood pressure. This is another complication of diabetes. This also raises your risk for a heart attack, stroke, eye problems, and of course, kidney disease. So why is it so important to go to your primary care provider? Your primary care will usually be your go-to person for treating your diabetes. They may also refer you to an endocrinologist that can help as well, especially if you have very uncontrolled blood sugars that they can't quite seem to figure out. Primary care providers will also check your renal function and determine if you have decreased kidney function. We get I'd say probably most of our patients are referred by their primary care provider or their endocrinologist. So the primary care providers, they determine your kidney function, your renal function based on your lab work. I know a lot of y'all probably look at your lab work on your own. There's that an app now, the My Mercy app. If you don't have it, I think it's great. It's really easy to download if you'll have a smartphone, and you can monitor all your lab work through the app. And a lot of patients, may ask for lab work to be printed off. That's something that's good as well. Just make sure that you're also, keeping an eye on your lab work. I have a lot of patients that come to me and they say, decreased kidney function. I've never been told that I have decreased kidney function before. This is something that you can look out for on your own. Your primary care provider is also looking at this, but I'm going to tell y'all what lab values to look at as well. So the two specific lab values that we look at are creatinine and GFR, which is glomerular filtration rate. I think that this is probably the easiest for patients to look at to determine their kidney function. The GFR is what I want you to be familiar with. This is a measurement of how well your kidney is functioning, and this is based on a percentage. So if your GFR is 50, you can interpret that as your kidneys are functioning at 50%, okay? If your GFR is 60, then 60%. So think of it that way. So next time you're at your primary care provider, something that you can ask is, what's my kidney function? And they should be able to tell you what your kidney function percent is.
Is the creatinine the same thing as the GFR? In other words, if you know the GFR, do you need to know the creatinine also?
I think the easiest thing for y'all to look at is going to be the GFR. We also look at creatinine as well, but creatinine can be the same in two different people, and your kidney functioning, your GFR is actually different. The reason why is GFR is based on like a formula that puts a lot of different things that basically plugs a lot of different things into it. Now, if you're African American, your kidney function is going to be different than someone that is not African American. And if you're a female, your kidney function is going to be a little bit different than someone that is male. So that's why your creatinine may be the same, but your GFR is going to be based on your race and your gender. So, and I'll tell you, the GFR, eGFR is what you'll look at your lab work. There's an African American GFR and there's a non-African American GFR. So make sure that you pay attention to the right one. So we see patients in nephrology that's GFR or kidney function percentage is less than 60%. Chronic kidney disease is defined as having a GFR less than 60% for over 3 months. So if some patients may have decreased kidney function for just a short period of time and it may get better on their own, it could be, from dehydration or maybe a medication that you're taking that could be hurting your kidneys. A lot of patients that have decreased kidney function, if your doctor tells you you have decreased kidney function, you also have diabetes, I would make sure to stay away from NSAIDs like ibuprofen, Advil, Aleve, meloxicam, naproxen, BC powder, medications like that, because, and this is just if you have decreased kidney function. If you have, normal kidney function, you can still take medications like this. This is just something that your primary care may tell you, maybe stop taking the NSAIDs for right now and increase your fluid intake. And I'm going to refer you to nephrology, and we'll see what they say. Question?
How to increase your GFR?
Do what?
How to increase your GFR?
So I'll talk to you about that. Some patients, your GFR can be decreased because of like a medication that you're taking that may be hurting your kidneys. Some patients' GFR could be decreased because of being dehydrated. There's a lot of different causes of decreased GFR. The number one leading cause of decreased GFR is going to be diabetes. Like I said, the number one cause of chronic kidney disease is diabetes. That's why I'm here talking to you all today. The number 2 leading cause of chronic kidney disease is high blood pressure or hypertension. I know a lot of y'all may also have, be on a blood pressure medication as well. So those are things that can cause your kidney function to be decreased. That answer your question?
Medication.
Do what?
What kind of medication will increase what?
There's a lot of different medications that can decrease your kidney function. When patient is referred to nephrology, we will go through every single medication to make sure that those medications are okay for that patient. One thing that I did just mention, though, is NSAIDs, so non-steroidal anti-inflammatory drugs. So anti-inflammatory drugs like ibuprofen, the list goes on and on. Basically anything with ibuprofen in it, those are medications that can lower your kidney function. It doesn't mean that it will lower your kidney function. If you have completely normal kidney function, those are okay medications for some patients to take. That answer your question? So primary care providers may also order urine studies to see if you have protein in your urine or something called microalbumin. Patients with poorly controlled diabetes or patients that have had diabetes for a long period of time, they may excrete protein in their urine. So the protein in your urine, it could be microscopic, which means that it could just be seen on a microscope. Or it could be seen by the naked eye. Some patients that I've talked to that have diabetes, they say, especially when they get dehydrated, they may notice foamy or frothy urine. So some patients have described it almost like a bubble bath in the toilet, and that can be caused by diabetes. So, we have patients, basically protein in your urine is a predictor of chronic kidney disease. You may have chronic kidney disease in the future if you don't have chronic kidney disease right then. So we have quite a few patients that are referred to us just for having the protein in their urine. It's usually due to diabetes, but there are other causes of that as well. Primary care providers will also order a hemoglobin A1c every 3 months. I don't know if y'all are familiar with this, so I'm going to kind of explain it to y'all. But this is a lab test that can be done every 3 months, and it's basically just an average of your blood sugar levels over the past 3 months. That's usually why your doctor is seeing you every 3 months if you have diabetes. It's so they can get an A1c along with other things as well. So the goal A1c, it may be different for every patient, kind of just depending on what your goal is with your doctor. But based on our nephrology guidelines, we want everyone's A1c to be less than 7. Now, that is to prevent progression of chronic kidney disease. An A1c of 7 is equal to an average blood sugar of 154 or less. So that's just something to think about. And if you get referred over to nephrology, we'll be sure to tell you all this stuff over again, okay? So how can you be kind to your kidneys? So I'm going to kind of just give you all some tips on some things that you can do to maybe prevent chronic kidney disease or make it so that you don't develop chronic kidney disease for a long period of time. Make sure that you're doing your best to monitor your blood sugar. Keep going to your doctor. Make sure you're getting all the lab work that you need to. I know it's a lot of lab work. You probably feel like you're, being poked all the time. But we want to make sure that we're staying on top of your A1c, that your primary care provider is doing a good job of making sure that your A1c is at goal, because that tells us that if you're doing a good job or not, monitoring your blood sugar, that A1c will tell on you. So another thing you can do is follow a diabetic diet. You may have access to a registered dietitian who can help you come up with meal plans. I know there's going to be a dietitian that's talking to y'all later on, and so make sure you pay attention to everything she says. And I believe your primary care provider can also refer you to a dietitian as well and kind of get you on a meal plan and make sure that you're eating the right foods.
What should you do if you have microscopic
Well, that's a good question. It kind of depends. So if you have microalbumin or protein in your urine along with microscopic hematuria, or if you have it separate, it just depends on the patient, honestly. If it's just hematuria and you don't have protein in your urine, your primary care provider may refer you to a urologist, which is different than a nephrologist. But they may refer you to us if you're also having protein in your urine. So it just depends. It just depends. Every case is a little bit different, so it just depends on the patient. So another thing that you can do is exercise regularly. This is very, very, very important. There's different guidelines. Definitely listen to what your primary care physician tells you about exercising, but they recommend you do frequent exercising, at least 3 to 4 times a week. Things that are not just regular walking. Dr. Chamaria, she mentioned brisk walking. Another thing that you can do is notice this guy's on a treadmill, but it looks like it's at an incline. That can also help you to, help raise your heart rate up a little bit. And you can get a good workout in. Timing for exercise, they recommend at least 20 to 30 minutes of exercise with a 5 to 10 minute warm up. So it's important that you get out there and exercise and be fit. Another way you can be kind to your kidneys is if you have hypertension or high blood pressure, make sure it's well controlled. You may just get your blood pressure checked at your visits, but if your primary care provider mentions that your blood pressure has been elevated, they may want you to go out and buy a blood pressure cuff and monitor your blood pressure at home. I always like it when patients come into my office and they have like a blood pressure log, so a log of blood pressure readings. That helps me out a lot because I can see, this patient's blood pressure is running like this at home. That's more helpful to me than just having one blood pressure reading in the clinic. I know a lot of patients have what we call white coat hypertension, and they come into the clinic and see the white coat and their blood pressure is, through the roof. So I like to have those readings from home. So if you do have a blood pressure machine, I think it's beneficial to your primary care provider, to definitely Dr. Chamaria and cardiology as well as us. So. Another thing that you can do to be kind to your kidneys is stay educated about diabetes. It's important to ask questions about your health and to stay informed. Ask your doctor provider about your hemoglobin A1c if you haven't already. Ask them about your kidney function if you haven't already. I told you all kind of, what to look for. And then, of course, monitor your blood pressure as well. So this is like what I said earlier. If your blood pressure is okay, you may just pay attention to your blood pressure. At doctor's visits, kind of know how it runs. But you may be asked by your doctor to keep a log of your blood pressure readings. And I really like that when people bring in blood pressure readings. The last thing that I have is to participate in the diabetes seminar like you are right now. This is a great way to start learning about managing your diabetes. So you're already off to a really great start. So I was looking at some diabetes resources online that I think are helpful. If you get out of here and you're like, what do we talk about? There are 2 really good resources. I think Dr. Chamaria pulled some information off of these resources as well. Diabetes.org. So this is by the American Diabetes Association. This website has a lot of helpful resources about nutrition, meal planning, fitness, weight loss, stress and emotions, preventing diabetes complications such as chronic kidney disease. And there's also an online community you can join to interact with patients who have diabetes. And I also saw on their website you can sign up for some free diabetes newsletters. They're available in English and Spanish. And you can have these sent to your house, and then you can also get emails as well. Another website that I think is really good is the cdc.gov/diabetes. So this is the CDC, the Centers for Disease Control and Prevention. They have, if you go to their website and click on Living with Diabetes, there's a lot of great resources available on this website as well, and they're available in English and Spanish. All right, here's these healthy, happy kidneys again. Do y'all have any questions for me?
What's the best time of day to take your blood pressure?
Oh, this would be a good one for Dr. Chamaria. But I don't really necessarily think that there is a specific, good time to take your blood pressure. She mentioned taking blood pressure once a day. I honestly like it when my patients bring in a log of twice a day, one in the morning and one in the evening. I would take your blood pressure maybe like an hour or so after taking your medications. That way it's kicked in and I can know, is this medication working? But then I also like to have an evening blood pressure reading as well. And the reason why is some patients, their blood pressure may be controlled in the morning, but maybe as that medication, might wear off towards the end of the day. And so if a patient's taking, 5 blood pressure medicines in the morning, I may say, hey, why don't we just take this one at night and see what happens? So I don't think there's a specific right way or wrong way or wrong time to take your blood pressure. It kind of just depends on, who's looking at it. Any other questions for me? Okay. All righty. Well, thanks for letting me come talk to you.
Thank you, Rachel. I appreciate that. We're going to move along to our next speaker, and it's Jenna Stephen-Morgan. Jenna's the outpatient registered dietitian for Mercy Hospital. She has many hats, one of which is our registered dietitian in our outpatient diabetes self-management training program. But she also teaches patients on medical nutrition therapy for a variety of other diseases and weight loss and weight management, kidney disease, GI disorders, and cancer. Jenna graduated from the University of Central Arkansas with her master's degree in nutrition, as well as completing UCA's 50-month dietetic internship. In addition to being a registered dietitian, she's also a certified personal trainer. This evening, she'll be presenting on nutrition and diabetes.
All right, can everybody hear me? Okay, like Liz said, my name is Jenna. I am the outpatient dietitian here at Mercy, and I do a variety of things, but one of my favorite things is community outreach, and community outreach in regards to diabetes education. So this evening, we are going to talk a little bit about a healthy eating pattern for people with diabetes. We've talked a lot about the word diet so far, and we've talked a lot about having a healthy diet, but we need to understand what that healthy diet looks like. So we're going to talk about that specifically for people with diabetes. We're going to demonstrate how to count carbohydrates. Just by a show of hands, has anyone ever been instructed to count carbohydrates? Some, okay. You don't have to necessarily raise your hand or answer, but After you've been instructed, have you successfully counted carbohydrates? So, usually kind of what I hear. Today, we are going to definitely learn how to count carbohydrates. In addition to that, we're going to learn how to read a nutrition facts label. Dr. Chamaria mentioned a little bit about looking at that label for sodium, but we need to also look at it for carbohydrates. So we'll look at how to read that label. Lastly, I want you all to understand your nutrition plan. Specifically, that word, your nutrition plan. If you look around this room, we are all different. We are different ages, we are different genders, we're different height, weights, have different medical history. No one's nutrition plan is alike. I see patients with multiple different medical histories. No person's plan, no person's goals are the same because we are all different. So first, what I want to talk about is the diet. When I say diet, I mean an eating pattern. There are many different quote-unquote diets, but diets don't work. That's why there are so many of them out there. When you go on a diet, you go on a diet for a couple weeks, but most diets are very restrictive. So when you hear me use the word diet, it's going to be just what we eat. A diet for someone with diabetes is often referred to as a consistent carbohydrate diet. And that is having consistent amount of carbohydrate foods at consistent times throughout the day, each day. We're going to look at that very specifically. But I want you to keep in mind that word consistent because I'm going to use it a lot. What do carbohydrate foods do? Liz talked a little bit about this in the beginning. Carbohydrate foods break down into sugar. Sugar is often referred to as glucose. Carbohydrate, sugar, glucose, starch, all of those things are the same thing. All foods break down into something. Carbohydrates break down into glucose. Meat, protein, breaks down into amino acids. Foods with fat, like margarine or butter, break down into fatty acids for our body to use. When we eat carbohydrate foods, like we've mentioned, carbohydrates turn to sugar. The sugar breaks down into glucose. That glucose gets into our bloodstream. That glucose wants to get into our body's cell to be used and absorbed for energy. Insulin is what helps that sugar get into the cell. So if you'll notice on the left-hand side, we have a defective insulin receptor. On the right-hand side, we have an intact insulin receptor. What that simply means is on the right-hand side, that sugar and that insulin are matching up. That sugar now is into the cell, our body absorbs it and uses it. It is out of the bloodstream. On the left-hand side, that defective insulin receptor, the insulin is there, but the insulin is not opening the cell door. The sugar can't get into the cell. The sugar stays outside of the bloodstream. When sugar is outside of the cell, in the bloodstream, elevated sugar over a long period of time, we now are struck with high blood sugar diabetes. Why is it important to eat carbohydrate foods? Many of my patients, when they come to me, they may have just taken carbohydrate foods out completely because carbohydrates turn to sugar and sugar raises blood sugar. So why don't we just stop eating carbohydrate foods? Is that the solution? Not necessarily, no. Because carbohydrates, remember, are our energy source. We have to have carbohydrates. They provide the body with energy. Our brain uses carbohydrates or sugar to think, function, process information. I don't know about you, but when I'm hungry, my brain does not work. It's because I need carbohydrates. Carbohydrate foods also provide more than just sugar. Carbohydrates provide certain vitamins and minerals. We're going to look at the different carbohydrate foods, but I want you guys to think of a few examples. Carbohydrates are breads. Whole grain bread provides a lot of fiber, as do other whole grain starches. Fruits are carbohydrates. Especially in this cold and flu season, what do fruits give us? Vitamin C. They boost our immunity. We need that. Lastly is milk. Milk provides calcium and vitamin D for our bones. So carbohydrates are more than simply sugar. Which foods are carbohydrates? Well, we mentioned the starches. Things like breads, cereals, things like grains, starchy vegetables. These would be things like corn and potatoes, crackers and snacks. Beans, peas, and lentils all have this starch component. Fruits are also carbohydrates, any type. Fresh fruit, frozen fruit, canned fruit, dried fruit, and fruit juice all contain carbohydrates. Lastly is milk. Milk and yogurt are in this carbohydrate group. We come back to carbohydrate counting, the most important tool for people with diabetes in their nutrition plan is to know and take action with carbohydrate counting. This is simply that method to count the carbohydrates at each meal and each snack. Because why? Remember that consistency. I recommend for patients with diabetes to have 3 meals a day, breakfast, lunch, and dinner, and to have a snack or maybe 2 snacks as needed. You'll hear a lot of different nutrition prescriptions or nutrition meal plans, ways of eating. Some people prefer the small, frequent meals. Some people prefer to fast and only eat 1 meal per day. This is going to vary among different people, but that consistency with breakfast, lunch, and dinner with the same amount of carbohydrate each day helps to keep blood sugar levels stable. If that doesn't occur, we tend to have blood sugars that are all across the board. I'll use an example. If someone wakes up at 6 in the morning and doesn't eat breakfast, but they go to work and they're using their body for energy, they're asking their body to move and provide them with energy, but they have not put any fuel in the tank, at noon, what do you think is going to happen? From 6 a.m. to noon, if we did not eat breakfast, we might overeat at that noon time. In addition to that, some people, especially people with diabetes, if you don't eat and you go to work, run an errand, take care of children or grandchildren, what does blood sugar do? Low blood sugar, very, very dangerous. So if you don't have these consistent meals, you are more susceptible to low blood sugar, overeating. What does overeating do at that noontime? Spike high blood sugar. Consistency is the key. I'm going to encourage each of you to use a book that is in that white folder because I want you to really have this information, this knowledge, not only here at our seminar, but to be able to take it home with you and understand how to put this into practice. In that white folder on the left-hand side, if you'll open that white folder up, there's a gray booklet in there called the Daily Diabetes Meal Planning Guide. It is the best resource that I have found to teach carbohydrate counting. If you'll open that up to the first page, And on the right-hand side where it says food list for meal planning, if someone doesn't have one of these, just raise your hand and we can get you one. On this page, it has all of the carbohydrate foods we talked about. It has the starches, it has the fruits, and it has the milk. Next to each food, it has a serving size. Does everybody see the serving sizes? All of those serving sizes are different. Each serving size of food on this page is equal to 15 grams of carbohydrate. I want you to just think about 15 grams of carbohydrate for right now. If you have a pen or need a pen, I can get you one, but go ahead and just write 15 grams on top of this page where it says food list for meal planning. I'm going to encourage you, again, I want you to have this information when you go home. So you can write 15 grams of carbohydrate is equal to 1 serving. If you don't have a pen and would like a pen, if you raise your hand, we can get you one. Again, to start counting carbs, think about 15 grams of carbohydrate is equal to 1 serving. Everything on this page, I call it the carbohydrate page, is equal to 15 grams of carbohydrate or 1 serving. Most women need approximately 45 grams of carbohydrate at each meal. Most men generally need around 60 grams of carbohydrate at each meal. I'm going to encourage you to write that as well, so you know when you go home, when you start counting these carbohydrates, about how much you need. It's important to note the per meal, 45 to 60 grams per meal. I've had patients who may have not heard me or misunderstood, and they think it's 45 to 60 grams per day. That is very, very, very low carbohydrate and not healthy. So to revisit, 15 grams is equal to 1 serving. Women need around 45 grams at each meal. How many servings would that be, women? 3. Men need around 60 grams, and how many servings would that be? 4. Excellent. If you have a snack would be around 15 grams of carbohydrate. The thing with snacks is that some of us have a snack, maybe not when we really need to have a snack. Is anyone guilty of that? I'll include myself in this. If you have a snack, think about putting a snack in between a meal when your meals are very spread apart. For example, let's use that example if you wake up at 6 o'clock and you eat breakfast by 7 o'clock and you're at work at 8 o'clock. And you're working from 8 to 9, 9 to 10, and you don't get lunch until 1 o'clock. Well, you've been up since 6 and had breakfast at 7, and now it's 1 o'clock. You may need a snack in between there with about 15 grams of carbohydrate to get you to that next meal. To again prevent low blood sugar and to prevent overeating and high blood sugar. But let's say someone else wakes up a little bit later, maybe is a little bit more sedentary. Maybe they wake up around 8, 8:30, They eat breakfast at 9, and they usually have lunch around noon. They really may not need a snack there. That 45 or 60 grams at that breakfast meal, if it's a healthy meal with some good nutrition, it will likely get them to when they eat lunch. Can you see the difference in those two? That's why it's so important to understand that nutrition is very individualized. No nutrition plan is alike. Some people may need higher carbohydrate. For example, an individual who works a very physically demanding job, a construction worker, who is working 8 to 10 hours in the heat or in the cold, is using more energy, demanding more energy from their body, they may need higher carbohydrate intake. An individual who partakes in very intense physical activity, a runner, a weightlifter, who again is exercising, using energy, asking their body for more energy, may need higher carbohydrate intake. 45 to 60 grams per meal is a very good estimate or guideline for general population. Next, we're going to do an example of counting carbs at a meal. We're going to build a meal with 45 grams of carbohydrate, so you get an idea how to count these carbs and what a meal might look like with the carbs. If you look in your book under the starches, you'll find bread. And one slice of bread is equal to 15 grams of carbohydrate. When you make a sandwich, you put 2 slices of bread. If you look in your book under fruits, you'll find one piece of fruit, a small, is 15 grams. How many carbohydrates do we have total? Sure, 45. Is this all you're going to eat at a meal? No. We need to add foods with protein and foods with fat. Protein foods would be things like meat, seafood, eggs, cheese. Foods with fat would be things like avocado, nuts, peanut butter. When we add these foods, they do not add carbohydrate. They only have protein and fat. Protein and fat help to slow the absorption of carbohydrate. They also provide essential nutrition for the body. Non-starchy vegetables are another group of food that have very little to no carbohydrates. These are the green leafy vegetables, lettuce, tomato, onion, cucumber, carrot. They're more water-based than starch-based. We should be trying to eat more of these non-starchy vegetables. When we put it all together, we still have the 45 grams of carbohydrate, the protein and the fat if we add meat and cheese to our sandwich, and add some non-starchy vegetables to our sandwich. That is how we count the carbohydrate foods. When you look at a label, the most important thing to look at on a label is the serving size and the total carbohydrate. Looking at the serving size first, looking at the total carbohydrate second. What most people don't realize is that the sugar is included in the total carbohydrate number. Individuals with diabetes are more concerned with the carbohydrate than they are the sugar. Sugar is a type of carbohydrate. All carbohydrates turn to sugar. The most important thing to look at on a label is the serving size and the total carbohydrates. Running through these very quickly because we're short on time. Desserts, sugar-sweetened beverages count as carbohydrate. A fun experiment to do is when you go home, look at how much carbohydrate is in a 20-ounce bottle of regular soda, and then look at how much we have per meal. I won't give it away, but I will tell you, you'll be surprised. Sugar-free products still contain carbohydrate. Sugar-free products, look at the label. Some may contain very little carb. Some may still contain the same amount of carb as regular products. Developing your nutrition plan, working with a registered dietitian. Someone who has diabetes often has kidney disease or heart disease like we've talked about today. Those are different dietary regimens, different dietary plans. Only a registered dietitian can help with all three of those things. Lastly, I'm going to leave you with a little food for thought, and hopefully you can read all of these. Nutrition is a very individualized science. Nutrition is not an opinion, although we do hear a lot of opinions out there. Nutrition is a science like other sciences. We want to make sure that what we hear and what we do are scientifically evidence-based. There are a lot of good resources, a lot of which we have shared, but some things to consider is that when you're reading something and it has to do with food, nutrition, or health, any health-related, is find if it's a credible source. Facebook, Instagram, all of those things are not credible sources, unless it's from a page that is the American Diabetes Association or American Heart Association. Does the information or offer seem too good to be true? If they're trying to sell you something, if it's a supplement, a shake, if it limits a food group, it probably is too good to be true. We're going to hold off questions so we can get to our next speaker, but I will be available after. So with that, I'm going to turn it back over to Liz.
Thank you, Jenna. It's always fun to work with Jenna. She has always good ideas and suggestions. Our next speaker is John Hall. He's a registered pharmacist. I guess that's correct. Yeah, there we go. He's a graduate of Southwestern College of Pharmacy in Weatherford, Oklahoma. He's the owner of Health Depot Pharmacies and Home Medical Equipment. He's been a pharmacist in the Fort Smith area for 28 years and been immunizing since 1998. And he's a board member of the Arkansas Pharmacists Association. This works with slow. This goes with slow.
Okay. Everybody hear me okay? So I'm going to try to get us back on track. We're a little bit behind. We'll try to get out of here on time. I'm sure everybody's getting tired of sitting in those chairs. As Liz said, I've been practicing as a pharmacist for about 28 years now, and in that time, I have seen the effects of diabetes on people and their families. Make sure I can get There we go. Okay. So in that time, I've seen the costs of most of the drugs skyrocket. When I first got out of school, Levemir was about $100 a vial. Now it's in excess of $300 a vial. When I graduated pharmacy school, the diabetics that we worked with made up about 2.5% to 3% of our patient base. Now it's in excess of 10% of our patient base. We've seen the disease accelerate drastically in that time in cost and the incidence of the disease, the number of people that have the disease, and across all age groups. Now we see new generation injectables like Tresiba that cost in excess of $600 a box, and the oral tablets like Januvia in excess of $400 a month. A little bit of a history on the timeline of diabetes. The first injectable insulin was developed in the 1920s. The first long-acting insulin came along in the 1930s. In the early 80s, we saw the development of the genetically identical Humulin-type insulins that we use today. Prior to that, all insulin was derived from cows and pigs. The reason I'm giving you this history lesson is to kind of explain that the high cost of insulin is not really warranted. If you compare insulin to, say, penicillin that came around in the 1940s, penicillin has been generic now for decades, and it costs pennies per dose. But we don't have any generic insulins. Why don't we have generic insulins? No one can really explain it, but it seems to coincide with drug companies' profits. And that's something that's a very hot topic in politics right now, and hopefully they're going to make some change in the future. So tonight I'm going to talk a little about medication costs of being a diabetic, why prescription insurance in general is a very important consideration, and some of the ways that a good pharmacy can help you with the cost and the management of your diabetes. The American Diabetes Association estimates that diabetes and prediabetes will cost America about $322 billion this year. 1 in 5 healthcare dollars spent will be for diabetes, and if you look at just Medicare alone, 1 in 3 Medicare dollars spent will be caring for diabetes. The average diabetic in their lifetime will spend about $100,000 on their disease, varying by the age at which they were first diagnosed. It's a very expensive condition to have, and therefore good insurance is a necessity. Tonight we happen to be together if you're Medicare age. Medicare open enrollment is going on right now through the 7th. I do suggest that everyone that's Medicare age review their plan every year. Compare your coverage and the medications that you take. This won't be a guarantee going forward. The plan that you're on will cover everything that you get put on, but it is a good idea to explore it every year. I'll give you a little bit of an example of how I see these things change from time to time. I had a patient that was on oral medication, and it was very inexpensive. It was about $15 a month with her insurance. And then she got moved over to injectable insulin that was about $600 a month, and it was non-formulary. So when she first picked her plan, she picked a very inexpensive plan, and the plan was fine for her at that time. But then when her diabetes continued to progress and she had to get put on insulin, the insurance didn't cover the product that the doctor went with, and so she was out of pocket $700 a month. And she couldn't afford it, so she starts changing up her regimen a little bit. Her diabetes goes off the rails and her blood sugars go through the roof, and it just didn't turn out very well. So when you're looking at a plan, you can't always rely extensively on what you're on right now, because that is going to change over time. We see things like this every day in the pharmacy. One of the biggest things that I talk to people about is if you're on brand name drugs, a drug that does not have a generic, you want to make sure and get signed up for the program that's available through the brand name manufacturer. These brand name manufacturers are competing with one another to try and get the diabetic dollars that are being spent, the $322 billion that are being spent. So they're all offering programs to get you to stay with their product. A lot of these programs will offset the cost of your drugs. They'll wipe out your copay completely. They'll knock it down from, say, $35 to $10. It's something that it's definitely worth seeing if you're eligible for. It's It takes about 15 minutes to enroll, and there's no reason not to do it. You just want to go to the drug manufacturer that you're on, so it would be like Tresiba.com or Januvia.com. Whatever the brand name drug that you take, they'll have their website, and it'll just be, mybrandnamedrug.com. And it'll have a discount program or a patient assistance program. You'll click on that, and it will tell you the eligibility requirements. There are usually some stipulations. Not everybody's going to qualify for every program, but if you're on 2 or 3 brand name drugs, this easily could save you $2,000 to $3,000 a year by enrolling in these programs. Okay, I'm going to go through some of the things that we see in the pharmacy every day that affect diabetics. One of the biggest ones that we see is formulary versus non-formulary drugs. This is when your doctor picks a drug, we'll say drug X, and you come in to get the prescription filled, and that's non-formulary. The insurance company wants you on drug Y. We have to go back to the doctor and say, well, their insurance has this other drug that's preferred. We need to get them switched over to this other drug. Usually that's because the insurance company has some sort of monetary arrangement with the drug Y. They're getting a kickback. So they're not looking at your best interest or what the doctor knows to be the best for you. They're looking at what gets them a little bit of a kickback from that drug manufacturer. That's just the way the world is working these days. But formulary versus non-formulary is something we see a lot. The other thing that we see a lot of is prior authorization. That's when you go in and the doctor writes a prescription, you bring it to the pharmacy. The pharmacy says, well, your insurance is requiring prior authorization. Again, this is usually a cost issue. The insurance company is trying to get out as cheaply as they can. So they're going to ask the doctor, couldn't we have used this cheaper alternative instead of just instantly jumping to this more expensive alternative? Again, not keeping your best interest or what the doctor knows to be best in mind. They're just simply looking at their dollars. Prior authorizations can also take on what's known as step therapy. They'll make you try drug A first. If drug A doesn't work, then they'll make you try drug B. If drug B doesn't work, then they'll move you on to the drug that the doctor had originally authorized. Usually this is all just a factor of time. Can take anywhere from 72 hours up to a week to 10 days to get a prior authorization approved or to get therapy change from say drug X to drug Y when it's a non-formulary drug. So it does take some time to get that done. The biggest thing that we see when people come into the pharmacy that are diabetic is we see day supply issues because there have been changes in their therapy over the last 30 to 90 days. They were told to increase their insulin use from 12 units to 20 units, or they were told to double up on their medication from 1 pill a day to 1 twice a day, or even 3 times a day. So what happens is you come into the pharmacy and it's refilled too soon is the word that you'll often hear. The medication, when we send in the prescription to the insurance company, we send them everything, the drug name, the directions, the calculations for the directions, all those things are sent in, and so they calculate your usage, and they know if you had your prescription filled on the 1st, you should have enough to last until the 28th, and when you come back in on the 17th, they're going to say that's too soon. They're not going to be able to get that today. So for that reason, it's extremely important anytime there is a change in your therapy, tell the doctor, go ahead and notify the pharmacy today, please. Most doctors don't handwrite prescriptions anymore. They all e-prescribe. They use their computers to send it electronically. Computers don't allow the backdating of prescriptions. So when you come in on the 21st and you say, well, back on the 10th, they told me to double what I was taking. So we need to get the doctor to give us a prescription on the 10th that says go up to 2 pills a day or go up to 20 units a day. They can't do that in the computer and have the computer electronically send a predated prescription for 2 weeks ago. And they don't handwrite prescriptions. So oftentimes that will end up with you having to pay for a refill out of your pocket because the insurance won't cover it early. If when you go in and see the doctor, and he tells you to double up or, increase your usage on your insulin up to a higher number of units, if they send that prescription in that day, then we've got documentation of that. When you come in early to fill the prescription, we can send that to the insurance company and say they were told back on the 17th to change their medication therapy, so they are now running out early, and we can get that approved for you. By a show of hands, just random people that have been affected by issues like prior authorization, early refills, step therapy, things like that already? Quite a few of you, okay. So there's programs out there called synchronization programs. This is something that I recommend for all diabetics. We do it at the Health Depot. The one that we use is called Simplify My Meds. Simplify My Meds is a synchronization program that fills or refills all your medications on the same day every month. So the way these work is we call you about a week before your prescriptions are due to be filled. We go through every prescription with you. We make sure you haven't been asked to change anything, you haven't had any side effects, haven't had any issues to speak of, and then that gives us that 5 to 7 days to contact the doctor if we need to make a change in your therapy because of a formulary change. If there's a prior authorization that has started, just because you didn't need one last month doesn't mean that your insurance company hasn't enacted some new requirement. You're going to need one this month. If you're out of refills, if anything has to be ordered, we can have all that done in that 5 to 7 day window from when the phone call takes place until your synchronization day. Then when you come in on that particular day, whatever day your synchronization day is, all your stuff's ready. It's all picked up on that day. You don't have to make multiple trips to the pharmacy. You don't have to remember to call in your medicine because we called you. It really simplifies your life. That's why ours is called Simplify My Meds. Most independent pharmacies are going to have synchronization programs. A few of the chains will have that. If you're mail order, if you're required to use mail order, you're kind of out of luck on that. So, but it is something that a lot of people, they're resistant to it first because they think, well, it's going to cost me more. It's not going to cost any more. It's the same cost. You may have to, if you get 7 medicines and they're $3 a piece, you're going to pay that $21 whether you do it all at one time on the 5th or you do it on the 5th, the 7th, the 11th, and the 14th. It's all going to be the same cost. And I do think that everybody we have on this program, it's just been a real benefit for them. Not only does it prevent them from running out of their medicine, it prevents them from coming in and not being able to get it today and have to come back tomorrow and worry about these things. It just makes things much, much easier. The next thing that we do that a lot of people should take advantage of is delivery. A lot of people don't realize that they can get their prescriptions delivered. You should never run out of your medications just because you can't make it to the pharmacy. You don't have somebody to take you to the pharmacy. The weather's too bad. You don't feel like getting out that day. Even if you don't want to use delivery, routinely, it is something that you should take advantage of. All the independents deliver for free or for a small charge. The people that are on the medication synchronization programs that get all of their medications at one time, that's just one trip a month. I think all pharmacies do that at no charge at all. So if you're on a synchronization program, you're getting 7 medications. They're all delivered to your house on the 5th. You're good until the 5th of next month. We call you, a few days before. We make sure nothing's changed. Everything stays the same. If there are any changes, we get those addressed and we deliver everything out again on the 5th of the month. You don't have to remember to call. You don't have to worry about whether or not you have refills or whether or not, this or that is going to be taken care of for you because it's all done in advance. One of the other things that diabetics often forget to use or forget to get their supplies on, things like test strips, syringes, pin needles, lancets, alcohol swabs, things like this. The insurance that you choose, it's very important that they cover these things as well. Oftentimes, supplies are not billed as prescriptions. So if you need a glucometer or glucose strips, things like that, they're billed on the DME side, the durable medical equipment side of your insurance. when you talk to your insurance person and you're working out what insurance you're going to get for the next year or the next term, you need to make sure that whatever supplier you're going to use for these products is covered. I know a lot of people here have to get their supplies mail order, or they've got to go to some place way out of town. There's some people in Fort Smith that even have to go as far as Northwest Arkansas, Rogers, to get their supplies, things of that, because it's a contract issue. If you have to go that far, you have to remember to call. Oftentimes you're not going to get your supplies. You're not going to get your strips. You're not going to check your blood sugar as often as you should. And, you know, if you're not checking it, you don't know what it is. You can't, you know, it's not a good way to manage your disease. So it is something you have to take into mind when you're looking at your insurance, is what supplies you're going to need, how often you're going to need them, where can you get them, is that place covered on your insurance, or is it going to be more of a hassle for you to go out of town or something to get your supplies? Something that happens to a lot of people is their glucometer will stop functioning, and it'll get, you know, gooey. It'll need to be cleaned, and it won't work correctly for them. It won't give them a correct reading. All these glucometer manufacturers have a test solution, a control solution. That's one way you can check those. If it's giving you fits, just get it replaced. Almost all the big manufacturers would rather give you a free meter so that you continue using their test strips than risk you trashing it and going and buying another meter. So the battery cover on the back of the meter will have a 1-800 number, and they're there. And if you call them and say, this meter's not working, I've tried this, I've tried that, then maybe we'll put you through a couple of little tests. And if they can't make it work over the phone, they'll say, I tell you what, we'll just send you a new one. You'll have it, you know, Thursday. That's usually what happens. You're welcome to, you know, bring that by the pharmacy. We can make that call for you. Worst case scenario, they'll send you a coupon, or they'll, you know, do something else. But the meters, there's even companies out there that will give you a free meter because they know you're going to be using their strips every day, you know, or every month from now on. So don't stop taking your blood sugars just because your meter has stopped working. That's not a way to go. So a few things that I just want to mention here, and then I'm going to take questions. Make sure if you do talk to your insurance provider, whether you're Medicare, age, or not, that the plan that you get covers everything that you're going to need, and from the provider that you want to choose, everything from your prescriptions through your supplies, possibly diabetic socks, diabetic shoes. If you're interested in one of the new glucose meters that is a continual glucose meter that you wear the sensor, make sure that your insurance will cover that before you sign up for the plan. Right now, as I said, is open enrollment. You can make changes to your plan now through December the 7th if you're Medicare, and it's a good time to look at your plan and decide if that's something you want to look at. Be sure if you're on any brand name medication that you take advantage of those brand name programs. As I said, it's not uncommon for those to save people $1,000 a year. It's easy to get, you know, one of those programs to take your copay from $50, say, down to $5, or even free every month if you're on a brand name tablet. Again, there are restrictions on those, so sometimes you do get excluded if you're on certain kinds of government subsidied insurance, or if you fall into a certain gap, but it's worth trying. It's free money. There's no reason not to take advantage of it. You know, you go on the website, it takes 15 minutes to enroll. The synchronization program, I think that's a great help for anybody that's on 3 or more medications, especially diabetics that may have to make frequent changes to their medication and that need supplies. With those synchronization programs, when we make those calls, we will say, you know, do you need any more test strips? Do you need any needles? Do you need any lancets? All that is put together in a package and ready for you to pick up on that day, your synchronization day. If we deliver it, same way, it's all put together and it's all delivered on that day. So you're pretty well set for the month unless there's a change. And if there's a change mid-month, we adjust for that so that that change runs out on the same day, your synchronization day. And so when the next month rolls around, it's all on schedule and just keeps rolling forward. Delivery, make sure that you don't have to skip your medication because you're not able to get out. Make sure that if the weather's bad, we can get it delivered to you usually. if you don't feel good, if you don't want to get out because the flu is prevalent and you don't want to, go stand in line at the pharmacy because you're going to get the flu, something like that, just have it delivered. Don't do without because you're not able to get by the pharmacy or your car's broke down or whatever the chance may be. The last thing that I'm going to have is a little something that I tell everybody. I think all these have came up tonight, but I always tell everybody to mind your ABCs. ABCs, A1c, goal for A1c is 7 or less. It's been mentioned many times. B is for blood pressure, 140/90 or less. And C is for cholesterol, total cholesterol, 200 or less. So those three things primarily are the most important, at least what I talk to people about. Your primary care physician and everybody else will have much more detailed things that they may go into with you, but for most diabetics, if they will monitor these three things and at least know what their numbers are and how they compare, they'll be well on the way to managing their diabetes and at least making the best of the situation they have. Yes, ma'am. Questions?
Okay. If I have Medicare, and I use Tracy
I don't know specifically about the Tresiba savings card. When you go on the website, it will ask you questions, and it'll tell you whether or not you qualify. And Tresiba.com. And the federal government, when they created the Affordable Care Act, they had these drug manufacturers put funds into the Affordable Care Act to offset the cost. And so a lot of the programs that are funding the Affordable Care Act, they won't give you an additional discount because they're already funding the Affordable Care Act, the Medicare programs. So a lot of times if you are on a Medicare subsidized plan, they will say that you're excluded from that particular card. But there are a number of the cards out there that are something that you can qualify for. Yes, ma'am.
machines last?
So I've got people that have been using those for 10 years. They do have a battery in them, one of the little flat button cell batteries. Most of them are smart enough to tell you if the battery's low, you can replace the battery. But if you clean it and it still seems to be working okay, I've got people that have been using them for 10 years and not had any issues. So the new ones, the smart ones that will track your blood sugar. You can hook it up to a computer and it'll print off a graph and the app and all that. They have firmware. I've had people that have went into their doctor's office and it be incompatible with the new version that the doctor's using because they have the old version. I've seen people make that call again. They just call and say, well, the doctor can no longer interface with mine because he's on a newer version than I have. They just send them a new one. Again, because, when the strips can cost, $1 a piece, let's say, and you're using one a day, they would rather keep you on that strip by giving you a new meter than risk you switching to somebody else's meter. So usually they'll just replace it at no charge. Yeah. Any other questions? I'd be happy, even if they're not related to what we talked about tonight. If it's pharmacy related, I'll be glad to. Yes, ma'am.
I use Healthy Pub, and I've never been caught, and I'm on that Finder Med thing, but they've never called me. Do they call from a local number?
It'll be from the pharmacy itself. Now, if we call, we'll call about, like I say, a week out. And if we don't get in touch with you, we just go ahead and proceed with the prescriptions. And then when you come in to pick them up, if there are any issues, we adjust it there. But it's designed for us to call you, like I say, a week out. And usually they'll call for about 3 days to try and catch you. If they don't catch you, you should see missed calls. If there's a way to leave a message, they'll leave a message. But if they're not getting in touch with you, you might want to make sure we have a valid phone number or something's going on. Yeah. Yes, ma'am.
I've just been diagnosed with pre-diabetic, and I'm on that metformin. And a couple of friends of mine that's on it or whatever said that there was something in the news about it was the problem with that. I haven't seen anything.
There have been a number of medications have been in the news recently because the byproduct of the process of manufacturing them has been shown to cause cancer. There were a couple of brands of metformin that fell into that category. They were being made by a facility that used a certain process that one of the byproducts of that process could cause cancer. It'll be taken off the market, those brands will, and metformin has been around for years. There's probably a dozen or so manufacturers, so there'll still be several other manufacturers that won't be in that grouping. And this is a very, very low risk issue because the amount, it's just trace amounts. The government really isn't even asking it to go all the way out to the end user. They're not wanting you to return your product or throw it away. It's safe for you to continue taking it. They'll just take it out of the marketplace, and then they'll make sure that the manufacturers are changing that process so that that cancer-causing agent is no longer there. Any other questions? Okay, I think we made it. Thank you for your time. I think Liz has a couple other things.
Well, thank you, John, for that. That's a lot of good information, isn't it? All right, a couple fun things and we'll be finished. In your folder, you're going to see a diabetes information seminar evaluation. You know, you can't go to anything without it having an evaluation. We would appreciate any comments that you have, but more importantly, look on the back and see if yours has a color sticker on the back. We have some door prizes. So does anyone have an orange sticker? An orange sticker?